To the January 29th version of the Montachusett Public Health Network. I will do the we'll do the roll call after I go through this little script, if that's acceptable to you. I now call this meeting to order. Please be advised FATV is conducting an audio and video recording of this meeting for public broadcast. I ask that anyone in the audience who is recording this meeting to please identify themselves for the record now by standing and stating your name and city of residence. I see none. At this time, I ask that all electronic devices be placed in silent mode. So why don't we do a roll call, Madam Clerk?
Certainly. I don't see Athol.
Oh, okay. Or maybe somebody else can do it.
Somebody has to mute.
Athol. Clinton.
Clinton's here.
Fitchburg is here. Gardner is here.
Gardner's here.
Hubbardston. Leominster. Phillipston.
Here.
Princeton. Royalston. Sterling.
Sterling is here.
Templeton.
Here.
Westminster.
Here.
Winchendon.
Hubbardston is here. I just couldn't get unmuted.
Okay, thank you, Hubbardston.
That was a hear from Jim for Winchendon.
Yes.
So thank you all again. I invite anyone in the audience who wishes to speak to please approach the podium, or at least raise your hand if you are virtual, and identify yourself by name and address, and identify the agenda item in which you would like to speak. You then may speak on that item for no more than 2 minutes. Seeing no one, I shall move on to the agenda. The first item on the agenda is meeting minutes. I do not have them in front of me. Has anybody reviewed the meeting minutes for the last meeting?
I moved the minutes.
We have a move. We have a motion. I guess we did. And
Second.
we already have a second by Micah. So any further discussion on the minutes? Anybody opposed to the minutes? If nobody's opposed, I will take it by unanimous consent.
Roll call. Roll call.
Oh, that's right, roll call because it's virtual. Thank you for the reminder.
As the man
Madam
behind the
Clerk.
curtain.
Okay, Clinton.
Good night. Except
Okay. Fitchburg.
Yes.
Gardner.
yes.
Hubbardston.
Yes.
Leominster.
Yes.
Phillipston.
Yes.
Royalston.
Yeah.
Sterling.
Abstain. I was not present for that meeting.
Okay, thank you.
That's not a reason to abstain, but that's fine.
Templeton.
Yes.
Westminster.
Yes.
Winchendon.
Yes.
Thank you.
Thank you all again. The next item on the agenda is New England Medwaste for shop collections. As you know, New England Medwaste has taken over. I believe they've already visited a few communities. So far, so good, I believe. If anybody has any complaints about it, please let me know. I know they haven't touched everybody as of yet, but take a look at your kiosks, your schedules, and make sure that the schedule continues like it did with our previous vendor, and that the schedule is adequate to meet the needs of the kiosk disposal. Is there any discussion on that agenda item? Seeing none, I will move on.
Yeah,
I have a question, Steve.
I heard it, but I didn't see it. Who was it? Michelle from Leominster.
Hi. We're thrilled to get monthly pickups in Leominster. We just got rid of, I think, 13 or 14 boxes last week. My question is, they did not leave a slip with us. Are they supposed to leave a slip with us or email it to us?
They emailed me a slip, so I did see, I can share that with you if you're tracking that for records.
Okay, that'd be great. Usually they leave us a slip and they didn't with this new company.
Let me just make a note of that. I will
Okay.
send it to you so you can keep a record of how much you disposed of.
Thank you.
You're welcome. Any other discussion on that topic?
In that same,
Abby from Westminster.
yes, the payment comes from us for pickup. So
So-
is that what the slip would be?
So the slip is mailed to the city of Fitchburg. The city of Fitchburg pays it out of the revolving fund from all the towns and then bills you for,
Okay, perfect.
to reimburse itself. Any other questions on the agenda item? It's, I forgot her name.
You have to go.
Stacy from
Oh,
Leominster.
Mike, sorry.
I just wanted to say that the first pickup, they didn't show up. And then when I called them out on it, they did show up the next time. So I was just curious if anybody else had a missed pickup, because that was not the way to start a new company, you know.
I don't believe anybody else knew the schedule. You were the first to inquire
Okay.
before I even had it, so I don't think that's happened with everybody.
Okay, I just wanted to let you know.
Yeah. Any other discussion, concerns? Okay, we will move on to the annual business meeting. I propose with a motion that we table the annual business meeting. That could be a time-consuming issue, and we have guest speakers. So rather than, I'd rather get to the guest speakers if there is any objection to it, rather than
Make a
spending-
motion, we table it.
And there's a motion from Tom. Do I have a second?
Second.
Second from Phil. We will table the annual business meeting to our next
I do have to
meeting.
do a roll call.
Yes.
Still need to
Yes.
vote.
Okay. Clinton,
Yes.
Fitchburg,
Oh, yes.
I was going to say yes on your behalf, but
Thank you.
Gardner,
Yes.
Hubbardston,
Yes.
Leominster,
Yes.
Phillipston,
Yes.
Royalston,
Yes.
Sterling,
Yes.
Templeton,
Yes.
Westminster, Winchendon.
Yes.
Thank you.
Thank you all. Next item on the agenda is Victoria with our MAVEN update on communicable diseases.
Good morning, everyone. It's nice to see all of your faces again today. Just a brief update on MAVEN and some data from MAVEN cases for calendar year 2024. I will be emailing each of you an annual report from MAVEN with some more specific details on your town, and that will be happening in the next week or so. But just for a general overview of what's happening region-wide for all of the towns that the MPHN covers, MAVEN, which is 10 out of our 13 communities, so these data exclude Leominster, Clinton, and Hubbardston. In calendar year 2024, there were 172 cases of reportable illness reported and investigated by the MPHN. These cases were definitely a bit more heavy in the second half of the calendar year. Since July 1st, we have had 61% of those 172 cases. So it's definitely been busy, especially throughout flu season. About 50%, a little bit over 50% of those cases represent enteric illnesses, including food and waterborne diseases. Common ones, Campylobacter. It's been a very busy year or I should say the end of last calendar year, very busy for norovirus. We've had quite a few communities reporting norovirus outbreaks in establishments, including food establishments, long-term care facilities, schools, et cetera, salmonella, and then a couple that we don't see very frequently, including cryptosporidium. We had a cryptosporidium outbreak in the MPHN this year. And so there was 87 cases of enteric illness in calendar year 2024. And each of those, per 105 CMR 300, involves a case investigation where we discuss with the patient their food history, employment history, any possible exclusion from work. And so those 87 cases are all quite involved. The next most common are tick-borne illnesses. We had 34 cases of tick-borne illness, reported tick-borne illness across the MPHN in calendar year 2024. And the remaining number of cases after the enteric and tick-borne illnesses account for a variety of other diseases, ranging from Legionella to vaccine-preventable diseases, invasive group A strep, hepatitis A, and others. I won't go through the specific case counts of these reportable illnesses for privacy reasons. Some of them we only had one case in the MPHN, and so to protect privacy, I will not share those specific numbers publicly. But I will note that we did see a notable increase in pertussis this year, and I think that is a trend that we're seeing across the state and across the country. So I will leave it at that for now. We have a busy agenda today, but like I said, I will share a report with each of the towns on the breakdown of what illnesses you saw this year and what types of illnesses most of the cases in the town account for. Does anyone have any questions?
Thank you. Any further discussion?
Mr. Chair, I have an offer for you.
I'm ready.
Not in my MAHB role, but in my role as the Shared Services Coordinator for the Islands Public Health Excellence Group, because I do that as sort of a side gig. We have in fact, the longest standing tenured employee of the public health program across the state is a guy named Patrick Roden Reynolds. And Patrick is a tick biologist, and he's currently working on several scientific papers. He's had a few that have been peer-reviewed and published recently about tick-borne illnesses. And if you'd like him, I'm happy to supply him in any one of a couple of different ways. Have him come to one of your meetings and talk to you about tick prevention. Or if you want to do a public forum, he has been known to take the ferry across and go to various areas across the state to talk to people about tick issues. And I had no idea that you had such a significant number there. I think I would have taken that up earlier with Victoria and made that offer directly. But if you want him, I can help to facilitate that.
That would be wonderful. If you would forward me that information.
Sure.
Yeah, I think that's a great contact. If any other discussion on the presentation from Victoria?
I just want to say, Mike, I think that sounds great. We've seen some cases of tick-borne illness this year, which we haven't seen for a while in the MPHN. Of course, there's some common ones that we see quite a lot, anaplasmosis, Borrelia, but there were a couple of tick-borne illnesses that, we just had one or two cases of, but we hadn't seen in quite a bit. So I think that's great, and the expertise is always welcome for sure. So thank you for that.
I'll connect to you.
Thank you.
Very helpful. Thank you.
That will be quite a journey from the islands to Fitchburg, but I like it.
Any other discussion? Okay, moving on to the agenda. Thank you all, and thank you, Mike from MAHB. We have, again, MAHB with a summary of the SAPHE 2.0 and the impact on local public health. I believe we have Catherine to start it off. And then
Yeah,
Mike.
just wanted to introduce Mike Hugo from Massachusetts Association of Health Boards, here joining us today to kind of give everyone in the MPHN and the public a summary of the SAFE 2.0 bill that passed in the fall and what that's doing for local health in Massachusetts, and just an overview of a grant that we work under, the Public Health Excellence Grant, and then falling into our next guest speaker to talk about the foundational public health services project that is going on with the state as well. So Mike, thank you very much for joining us. I really appreciate it, and it's all yours.
The floor is yours.
Thank you very much. I'm going to share my screen, and I think when I do that, I lose the ability to see faces. So if somebody has anything that you need to do or say or ask, just jump right in, because I'm going to keep going. I've got loads of slides, and the reason I have loads of slides is that I'm going to supply them to you afterwards in a PDF. So you're going to see that I'm going to go through some and say, read this later, because I don't want to kill you to death with slides right now. So I'm going to share my screen.
Excellent.
And you can see this now, I presume? Can you see it?
Not quite yet.
Not yet.
Really? Okay, that's not good news.
We can see Judy.
Well, it says here that I am sharing my screen. Let me stop it and try it again.
Yeah.
Share. Screen 2.
There we go. That's better. That worked.
Okay, excellent. So now let me find where let me slide you down here. So are you seeing slides now?
No, we're actually seeing your home screen, I think.
Okay, let me stop share one more time. Let me bring this over here and go back to share, hopefully. How about now?
We're back to seeing Judy.
Okay. Let me go this here. Let's see here. I'm just going to shut those all down. Okay, now I should be able to. Are you seeing slides?
Yes, we are.
Perfect. Okay. All right. So, thank you for inviting me. And I'm going to start out by talking about the PHE grant, and I'm going to fly through this because you guys are extremely sophisticated and extremely up to date, and obviously from what I've seen right now, you're functioning on a lot higher level than 99% of the other groups that we've come across. So I'm not going to get too deep into this, but the idea behind the Public Health Excellence Grants is that, in fact, let me go to this now that okay, so that changed it, right?
Yes, it did. Made it nice and readable.
Okay. So the idea was to expand shared services or to create shared services arrangements, very similar to what you have been doing for quite a while in Montachusett, actually. So, so what we have is a state program to basically bring everybody to a same level of functioning, and it comes from the report of the Special Commission on Local and Regional Public Health. The Special Commission was convened in 2016, issued this report in 2019. It's 160-something pages long, and it's available online, or if you need it, I can just send you all a copy of it, and then you can have it if you don't have it already. But if you don't have it and you've never seen it, you really should take a look at it. It's findable very easily on Google as the Blueprint for the Public Health Excellence Program, and you can find it, and I think you should take a look at it. But basically what it says is that public health in Massachusetts is broken. And easiest way, not the easiest, but the best way to fix it is to increase cross-jurisdictional sharing of public health services. And I'm not going to read these slides to you. I've always said there's a special place in hell for people who read slides, and I ain't going to do it. So, but what happened as a result of the report was that the Public Health Excellent Grant Program was rolled out in fiscal 21. Was actually fiscal 22 was the first year it was. Fiscal 21, it was the first year it was funded. Sorry. And today we have 321 cities and towns of the 351 in 51 sharing groups across the state. And it provides a vehicle for sharing services, for attaining technical assistance beyond MAHB's been here for years. So it's beyond what we've been doing for years. You're about to see one of our technical services provider partners when I get done, and that all is made possible through this grant program. A key piece of it is health and racial equity training, and I know that the racial equity piece is more important in some parts of the state, but health equity is important right across the state. And you're about to see the results of the health equity piece when we talk a little bit about the data collection that's about to happen and how all boards of health will be treated the same across the state as a result of the equity piece. Governance is you're doing it right now. That it's basically a governance board, one town, one vote. But the last little note on here that it's a shared, not loaned or borrowed services program is very important, because some of the groups look at the employees as if they are an employee of the town that is the host community, and that's not the case. The employees of the grant are employees of, in your case, I think that there's 14 or 13 towns. I counted 13, but I think that there might be one missing from my list. But your employees are shared. And Royalston and Hubbardston and Wichenden have as much right to those employees as Fitchburg and Gardner do, and that's part of the model is totally shared services. Each town gets to vote on every decision. I know that there's been, and I'm gonna just put it right out on the table. I know that that there's been some feelings by. I know Hubbardston, and I was there last night, is feeling as though they're not getting great services. That's something that is easily taken care of, because I think that just attending and speaking up at meetings puts you on the map, literally, and makes you a part of the decision process. And I'm hoping that each of the towns that are involved in the grant program are getting the same courtesies and the same services. Decisions about making the hires, those are group decisions. If some groups think that they need 2 inspectors and no nurses, some groups think that they need 2 nurses and no inspectors, some think that they need an inspector, a nurse, an epidemiologist, a community outreach, and whatever. There are many different slots and categories that are being hired, and those are completely your decision. And hopefully they're informed decisions that you've thought about what your needs are, and that we had the capacity assessment that I'm going to talk about for a half a second as I fly through here. This is what the map looks like. You're seeing some white spots on the map, and many of those white spots are either asking to get in or in the process of joining other groups right now. The group that you're looking at in the southern part of the state, the southwestern part, that's around Springfield. That's a group in formation with the exception of the city of Springfield itself. All of the other towns around it are looking to combine, and we're trying to work with DPH on them. There's a group up in Essex County of 4 or 5 towns that we're trying to figure out how to do that. As you can see, they're disconnected, but we're going to find a way to fit them in. And many of the white spots are now coming to us and asking DPH whether or not they can get into a group. And we're working with DPH to try to work with those boards of health to get them situated with one of the groups that they are contiguous with. You're the big purple mass in the middle on the north. And I'm not going to go through this because I sort of just did, but the bottom red line is the most important to me. It's getting all ships on an even tide so that no local board of health is lacking anything. You all should be functioning on the same level as the city of Boston does. And the funding is here to do that. Of course, the original intent was to spend most of your money on sharing, on hiring, I'm sorry, and these are a few of the categories. You won't see Patrick on there because Patrick was a interesting compromise. That's the tick biologist. We couldn't get the islands interested in participating until I mentioned the fact that you have ticks here, don't you, and don't you need a biologist for that? And they went, we can get a biologist? I said, yeah. Then I got yelled at by DPH because they didn't want to fund a biologist. But I said, hey, I committed your money, so you now have a new group. So it worked. It worked beautifully. So here's where the funding is. The funding is actually, it's 2 federal grants plus a line item. This is the biggest of the 2 grants. This is the ARPA funding. After ARPA was announced, all of your cities and towns across the whole state, but all of your group, they all took lots and lots of ARPA money and gave little, if anything at all, to public health. We went as a Coalition for Local Public Health. We went to, and the coalition is MAHB, MHOA, MIHA, the nurses, Western Mass Public Health Association, and I'm forgetting one, and I'm sorry, but and so we went as a group to DPH and actually went to the governor and said, hey, this is a public health issue. Why did you give all of this money to the cities and towns without any tie to public health? Oops, we made a mistake. Here's $200 million. So we got $200 million, and with that, this is how it got broken down. You're going to hear a lot about the data system, I'm guessing, from BME in a couple of minutes after I get done, and workforce development, capacity building, and those are the sums of money that are being poured into these. Every single health department in Massachusetts will have exactly the same computer platform paid for and installed by the Commonwealth, by the Department of Public Health, under that first bullet, under the data systems. That's what they're working on rolling out right now, and I'm not going to step on the next speaker's toes with any of that. Of course, MAHB was there, and you all know Cheryl, and you know how we feel about boards of health. And by background, I served for 15 years in the Framingham Board of Health, 8 of which was as chair. And I got involved because at the time I was an environmental lawyer, and we had some environmental catastrophes happening in Framingham. And so I got on the Board of Health to try to help with that. And so I've been jealously guarding Board of Health authority. Framingham doesn't like their Board of Health, mainly because of things I did when I was the chair, shutting down a company that was a huge taxpayer and drove them out of town, and started identifying very embarrassing trends in the environmental justice neighborhood where the city wasn't taking care of people because they couldn't speak for themselves. So we did. And so I understand the importance of a Board of Health. And so MAHB, all the way through this whole process, has advocated that we won't stand behind it, which would mean that the coalition wouldn't stand behind it, unless autonomy of each of the boards of health was protected. So you continue to make all of your regulations, you have the hearings, you have the enforcements, all of those happen in each of your Board of Health meetings, even though it's a shared inspector that might bring this to your Board of Health. They're still working under your public health guidelines. The Special Commission set forth some workforce standards. These become very important in the next part of the talk when I start talking about the new law, because these are now law. That doesn't mean that if you are a health director or an assistant director, deputy director, and you don't have a master's degree or a bachelor's degree right now, you'll get grandfathered. Nobody's losing a job here. And that's very important to keep in mind, that we're trying to build capacity, not destroy capacity through the system. But there will be, these are now going to be in effect, these standards, and people who you are going to be hiring in the future are going to have to live up to these standards. It's in the process of being implemented right now, and we're going to get into that in the next part when I talk about the law. These are the requirements and recommendations for what you have to have as an inspection type. So if you're doing food protection, for instance, I know that you have some board members there that do food inspections. There's going to be some minimum standards that are going to have to be put in place. These are going to be sooner than later. This is not going to get grandfathered. Although if somebody doesn't have these things right now, nobody's going to say you can't do it. They're going to say start working on it right away. And we will help, and certainly BME is a tremendous asset when it comes to helping to plug you into some of these trainings also. And you'll, I think, be hearing about that in a couple of seconds. This is the group and I don't think I've missed anybody, but if I have, please let me know. But this is
You haven't. That's all 13.
Okay, excellent. So this is the group that did the capacity assessment, and you all remember that, the CART, as it's called, that was a baseline. And you know, I'm sorry I didn't get a chance to come to your group before you did the capacity assessment. I should have come to each of the groups, because in retrospect, what happened was people's human nature kicked in, and when you were asked, how are you doing? You know, if you're anything like me, when someone says, how are you feeling? I always say, good. And my wife always goes, good. You've got COVID. What are you talking about? You know, I mean, that's, we all want to look good. And that came into play, I think, a little too much. And I was going around to groups saying, no, the worse you look, the more money you're going to get. You want to look bad. So lay it on the line. And a lot of people said, well, yeah, we're kind of getting by with that. When you should have said, no, we just are not making it there, because that's where the money went the first time around. It's coming back, and it's going to be coming back, and I'm definitely not going to say more about that, because that is the next portion of the speakers today. But you're going to have a chance to really identify what your issues were. This is your group. You actually were a little above the state. You're on the right. Comparison number 2 is your group. You're a little better than the state average, which is good. This is your staffing. You can look at this slide later. But this is a little disturbing. The orange dot is your group, and you can see this is the expenditures, and you can see how much money you're not spending on public health. And I think that if you had done a more complete, and this isn't your fault, I think everybody that falls below the average is in this group, that people they didn't understand the capacity assessment. And that part of that, I think, is because DPH, I don't like the way that they rolled it out. I don't think anybody liked the way it got rolled out. But the results, it's garbage in, garbage out to some degree. And the funding, your funding might be more than this. That's what I'm finding when I talk to the groups, is they say, no, we funded better than that. So again, it was the first time through. We've never done a capacity assessment. You're going to get a chance to really do it all over again in much more detail, which you'll hear about in a second. So this is a model that you don't follow. It's not like if it's Tuesday, the inspector will be in Clinton, and on Thursday, the inspector can be, in Westminster. That's not how it works. It works, the way that it should work is that your shared inspector looks at your entire map and sees it as one municipality. I am now in charge as the inspector of all low-risk food. I'm also in charge of all housing. So I don't care what town it's in, I've got to get to that one and go do that inspection. Just like it's one town. One great big mess on the map, and a lot of territory. And I think maybe too many towns, and I think that you probably feel the same way. And a lot of mismatch and disparity, I think, because of the way that your group fell together. And that's something that we will hopefully be able to address with DPH in the coming years. It's not going to be this year or next, but it may be when we get to the next phase of funding, we can figure out how to address that, maybe with more money so that you have an east and a west or a north and a south. region within so that you can get additional inspectors, additional nursing. I think you're really well covered with epidemiology. You've got one of the best there is, so obviously we're not worried about that. So why the grant? Well, the grant came from the original SAPHE legislation, SAPHE, was actually State Action for Public Health Excellence, and that's the way I still call it, but the real name of the bill was an Act to Accelerate Equity. You see that there, AKA Statewide Accelerated Public Health for every community, and that's how we came up with SAFE 2.0. We needed to make it fit the original. And it basically now, everything in the report of the Special Commission that I recommended that you download and take a look at, everything in there is now law. And it's all under Chapter 111, which is, of course, the Public Health Statute, and it's Section 27D. And if you go online when you get home or later today and look at 111.27D, what you're going to see is the old law, which was before the statute that was passed 2 months ago. And it's tiny compared to what it is today. It's been completely revamped. It's just not up online yet because they're still figuring out how to implement it. We're kind of like the dog that caught the car. We get the bumper in our mouth and we don't know what to do next with it. So we're working on that. And that's another thing that BME is so pivotal in helping us to implement across the state. So what is the new law? Section 27D has an A, B, C, D, and it goes all the way to L. And I'm going to take you through them without enumeration, but I do have, MAHB has online, and I will supply it to you guys through your shared service coordinator. We have a guidance document that takes you through the new statute section by section. But this changes life for everybody on this call because we now have to do things. There are obligations under the law that we have to supply certain things to our cities and towns, and we have to increase services and certifications and things of that sort. So the DPH under I think that, well, A is definitions, but I think this is section B. DPH has to establish this program, and obviously they've already got a really good head start because that's what we've been doing for 3 years now, or 4 years, in some of our cases 5 years. But to address equity and to increase efficiency and effectiveness. And DPH has an obligation under the statute to provide adequate resources. DPH has to be in a position where they can afford to do everything that they're telling you to do. Otherwise, it's an unfunded mandate. What prevents it from being an unfunded mandate for the cities and towns that are not in the program now have to scramble and get into the program because it's funded if you're a member of the program. It's actually technically funded if you're not, but the advantages are all going to go to members of the Public Health Excellence Program. So MPHN is covered. All of your towns are part of the program. When you apply for trainings, and if you can't get into a training that's live and you're put on a waiting list, you'll be on that waiting list, but if you're not a member of a PHE group, you'll be on the waiting list, but the PHE groups are always going to be jumped ahead of you. So if a city or town is not in the program, as a practical matter, they're probably never going to get reached on waiting lists because, as you know, there's a lot of turnover right now going on across public health, so there's a lot of new trainings that are necessary. And really, the idea is to increase, and the word increasing cross-jurisdictional sharing is in the statute. And the reason that increasing is there is because of the 30 or so cities and towns that are not part of cross-jurisdictional sharing groups. So DPH has an obligation to get those towns in. And of course, they look to MAHB to help them to carry that obligation out. And that's what we do. We have a contract to do that, and something I've been doing for years. The new standards for inspection are there. Those are the ones that I showed you on that second page of the graph. And there's new epidemiology requirements that never existed before. Education, training, and credentialing are now by standards, like I showed you. The boards of health shall implement and comply with the standards above individually or through cross-jurisdictional sharing. So what that means is the legislature has told us that for a city or town that's not in this program, they've got to go it alone. And much of it will be at their cost, because even though the software will be paid for and the hardware will be paid for the computer systems, you're still going to have some mandatory reporting. And the reporting you're about to hear about from the next speaker is, you'll see that it could kill you. It could kill you if you're a tiny town, and you have to live up to these standards, and you have to do this reporting. So just because you're not in a group doesn't mean you don't have to do it. So I think that that's going to be an impetus to see more towns try to get in all by itself once they see the Herculean task that lies ahead. It's surmountable, but it's very demanding. You're going to need a lot of time and effort. And please, 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 don't make the same mistakes and I'm saying this to every group that I speak to. Let's not make the same mistakes that we made on the original cart. Let's really lay it out there so DPH knows exactly how much backfill to put over everything so everything's equal and level. Boards of health have to submit a report annually. And that's done on an individual board basis. This isn't the collaborative, although the collaborative will probably, especially in your case where you're so well organized, the collaborative probably will author that report for you, or certainly with you all the way through. This is going to also be burdensome to the cities and towns that are not part of it, but that's not you, so don't worry about it. These slides, they look scary. They shouldn't look scary to you, but there are cities and towns I've been in front of that I tell them, you should be scared. You have reason to be very scared. So get into a group. DPH and DEP have an obligation under the statute to provide free trainings, and much of that is now online. I don't know whether or not you've heard and whether or not you're up on the Train Mass program or things of that sort, but everything's online pretty much, with the exception of the things like, the soil certifications and things where you have to be hands-on. But you can get online trainings across the board. Board members, MAHB is we're doing 3 regional ones. We're doing one in Northampton, one in Worcester, I'm sorry, one in Marlborough and one in Plymouth. And Cheryl and I are now talking about, for the first time, doing a couple on Zoom and recording them and putting them up on our webpage so that people can just go and look up that particular section that they need some help on, and it'll be visual rather than something in writing. I don't know if any of you have been to our programs, but they're on Saturdays, and they start with a really good breakfast. We give you a great lunch, an afternoon snack, which I guess it was last year, during the afternoon snack, one of the health inspectors that was at the program held up his candy bar and said, check the date on the candy bars, they're 18 months expired, which was really good for the hotel that hosted us to see all these health inspectors catch him with a bad candy. Anyway, but that was kind of fun. So DEP and DPH have an obligation to provide funds to boards of health to implement and comply with the standards. So that's a piece that we're working on. And right now, just so you know, the funding for the program, in addition to those two, we have the $200 million ARPA. We have a $52.6 million FIG grant, Public Health Infrastructure Grant from CDC. So those two are the federal grants. But we have a $15 million line item, which right now was funded this year for $9.1 million, and the governor's explanation was that you have this other $256 million from other funding, but when that runs out, we know that's only temporary, that's going to run out, and we are going to cut you to 9.1 this year because you don't need it and other people do. And so this particular year, well, the first year we came in at I think we asked for $7 million the first year, got it. Second year, we asked for $13 million. I was living in Framingham at the time, and my wife and I are actually social friends with the Senate president. And she called me up and she said, I see $13 million on your line item for this program. I said, yes. I said, you're going to give it to us? She said, well, I don't think that's enough. And I've never heard a senator say that to anybody. So she upped us to 15 million because she thought that that was more appropriate. And that became our benchmark number. And so when the governor cut the 15 million, they funded us twice for that. And the governor cut it this past year for 9 million, 9.1. And she said, I know that this is a $15 million line item. We're just doing it because of the other money you have right now. This year, in her new budget that she introduced last week, the only program that I'm aware of in the entire Health and Human Services budget, which was cut by $100 million, the only program I know of in their entire budget that was not cut at all was the Public Health Excellence Program, the SAPHE program. So they level funded it at 9.1. I have spoken personally with Lieutenant Governor about reminding her that, the 9.1, just because you've given us that again, you're not forgetting the fact that we've had several conversations where you and Maura Healy have promised me face to face that you're not going to affect that $15 million. And she said, oh, no. She said, we're anticipating actually that it's going to be considerably more once the 9.1 runs out at the end of your current funding, which is for 3 years. We're anticipating it'll be a bigger number than that, and we understand the importance of this program. So we're in pretty good shape that way. Anyway, that was sort of a side story, side trip. I do a lot of those. So the DEP and DPH have an obligation to measure the effectiveness, and that's what you're going to be hearing about in a moment. That's the public health standards that you're going to be hearing about in a couple of seconds. And I'm coming really to the end of where I want to be right now. But also there's biannual reporting by DEP and DPH to the state, and they have to include in those reports what boards have met it and what boards haven't met it, with all of the data that you're about to hear about in about two more slides. I'm almost done. If a local board is not performing adequately, the state under this statute, the DPH at that point has an obligation to not take over. There's no power for them to take over, but they can cut funding to various boards of health if you're not performing. So that's not going to happen. I don't think it's going to happen to certainly not to any of the boards of health that are in the Public Health Excellence Program. It's just the fact you're in this program is going to make sure that you have enough money to do what you need to do. And with all of the support that BME is giving and that we're giving and that MHOA is giving, it's going to be impossible to be in that bad situation. And this is where we end, but I just want to say that the last section, 27DL, says nothing in this section shall limit, I will read this slide because we made it happen, shall limit the authority of the Board of Health as otherwise established pursuant to general laws. In other words, nothing in the whole PHE program takes any of your powers, your duties, your ability to pass regulations, your ability to enforce, to shut down chemical companies if you have to shut down asphalt plants, which is going on in a couple of cities and towns right now. We're dealing with towns on terrible water situations, and we're helping Plymouth right now. They want to dump water, the contaminated radioactive water, into Cape Cod Bay from the nuclear power station. NRC, DEP, EPA couldn't stop them, and the Board of Health did, which is very interesting. That's how much power you have, but that's for another whole other speech that I bored Hubbardston with last night. But you have incredible power, and we are protecting that power. And if you're ever feeling like you're losing any of that, please let Cheryl and I know immediately. And with that, questions, and I'm going to stop sharing so I can see all of your beautiful faces.
Thank you, Mike. Any questions from the group? I see Phil.
I just wanted to throw out there, for those of us who have been around too long, that the there's always staff changes. There's a lot of new faces in DPH. There's some of us that have been around that are embedded there, like Dr. Wong and some folks that have come up through the ranks. But I guess what I'm saying is I hope that the newer folks are given a sense of where we've come from and what it took to get here, and not to forget about that, and then don't assume that everybody is in the same place. So this data stuff, this reporting stuff, that's going to be added effort on our part, especially for our smaller boards that, have a part-time admin like 4 or 5 hours a week, that's it, and basically volunteer boards. So I know we're all supposed to be on the same page and we're all supposed to be doing the same thing, but we all don't have the same resources. And I find there are times when the road that was traveled is an assumption, and the effort, this effort goes back into the 90s when the state was divesting themselves of regional sanitarians, and a lot of the work got dumped on us. So anyways, it's not anything that we personally can do, but I do run across that sometimes with some of the newer folks that are in the system.
Bill, what I say to you is that, I've been around a while too, and interesting fun fact is that when I was the chair in Framingham, we had a health director who left and went to work for Steward Health, and you saw how that went from Massachusetts. And when that health director announced that he was leaving Framingham, the next health director that we hired as our health director in Framingham was a guy named Sam Wong, who was the health director in Hudson at the time. And Sam and I have been friends for like 30 years. And I know that Sam comes from the same stock as everybody here. He is a former health director. He started as a food consultant. We used him as a food consultant in Framingham before he became a public health official in any way. I will say that as long as Sam Wong is there, you have a very sympathetic ear. And if anybody here feels as though your board is getting steamrolled in any way, shape, or manner, if you contact me, I'll help you with that, and I will get the right ears of the right people. And I know that it's overwhelming, because those who remember Ron O'Connor as the director of the Office of Local and Regional Health will remember that it was Ron, and he had maybe a staff of 4. Sam's staff, I think, now is approaching 50. So it's huge. The program has a lot of back end to it. Because now DPH realizes that, there's a lot going on in boards of health. And Sam has built that program. But I've heard that before, and to be totally honest, I've felt that before myself, that is this staff member getting it? Start with me, if you would, and we'll have a frank conversation about it. And much of which will probably be off the record when we have that conversation, so that I can help you to understand if you're feeling anything. But you're not alone. I've heard that before, and that's one of the functions. That's one of the things, our technical services contract that supports MAHB, we're member supported from our dues, but we have a series of very large contracts with DPH to provide legal technical assistance and PHE grant technical assistance, and the legal technical assistance piece is very broad, and so we can help you to advocate if you're feeling that way. And that's not just to Phil, that's to any of you that if you feel like you're not getting something, start with me. I'll help you to get to the right person. And very often what ends up is within a day or two of that conversation we have, we will get either Sam or, like later today, I have for one of the groups, Caitlin Pettengill, who is the head public health nurse for DPH. Caitlin is meeting with a health director to talk about a particular issue involving nursing in their town. So that's one of the things I do all day long is facilitate issues. So start with me. I'll get the doors open. Very often I end up going to BME, by the way, and which will, sort of give a transition here. But BME is providing lots and lots of nuts and bolts types of technical assistance. I'm not sure what the technical term is for what it is, but it's real nuts and bolts stuff, and we can help you with all of that stuff.
Excellent. Thank you, Mike. Any other questions, concerns? I don't think that was a hand, right, Kyla? That was an itch? Okay, thank you very much. Very informative, a lot of information.
I'll make these slides available, by the way, because first of all, we have to, it's an open meeting. And so, for the OML, but I'll send these slides on to you. I will also send you a PDF of the report of the Special Commission and a PDF of their executive summary, which is way less than 160 pages long, but doesn't contain that graph that I showed you. So don't look for it there, but look for it in the report. I'll send you copies of that so you can distribute those out to people if you want, along with our guidance document on the new statute. Today, I'll send them later.
Perfect. Thanks again.
Thank you. I'm going to sit and watch because I can't figure out what you're about to be talked about, and I've been through this training 9 times, and I still can't figure it out. So.
Kyla will be our hero. Thank you again, Mike. We really appreciate that. Was a fabulous overview, and I think that everybody here probably has lots of takeaways. I appreciate you for coming and for all of that you did to explain things phenomenally. So thank you, Mike, again. And next we have Kyla, who's going to talk about FPHS, which Mike gave us a great introduction of what's coming next. And Kyla's going to talk about what's coming next, which is this Foundational Public Health Services Review. Kyla is our technical assistance guru from BME Strategies, and Steve and I met with Kyla last week to kind of give her an overview of the MPHN, and I think joining this meeting from the beginning, she's got a great handle on it even more now. And she's been extremely responsive. I have to say that I have had lots of conversations, emails back and forth with Kyla that have all been resolved. I had 2 people reach out to me, 2 health directors reach out to me that had trouble getting into the tools that were sent out, and I have a 100% record of helping them get in. So come to me first, but I will go to Kyla as needed. Kyla, go ahead and take it away.
Thank you so much. I'm going to go ahead and share my screen. I'll try to make it quick because I know we're all antsy. At least I am. So as Catherine said, I'm Kyla. I am an associate public health consultant with BME Strategies, and I'm working with the Department of Public Health on the Foundational Public Health Services Shared Services Review. So I'm just going to go through what the FPHS, or Foundational Public Health Services Framework, is, what the review will look like, the timeline, and then some next steps. I do want to start by saying that the local Board of Health weekly webinars, the past 3, have been focused on the Foundational Public Health Services Review. All of those have been recorded and are in the SharePoint folder that Catherine mentioned. So if anyone wants access to those recordings, you can reach out to me or Catherine, and we can make sure that you have access to those recordings, and they have all this information and much, much more. So what is the FPHS framework? It defines a minimum set of services that must be available to everyone in the Commonwealth, and although these services do not need to be delivered by local public health is responsible for ensuring that these services are delivered by some entity to your constituents. It's made up of 5 foundational areas that are shown in the circles and 8 foundational capabilities, which are shown in the rectangles below. And I'll go over these a little bit more in a little bit. So the shared services review is made up of 2 data collection tools that will be used to document existing resources that you have in local public health. So the first data collection tool is the cost tool. And this tool is going to be collecting information on the resources that you have and how you're spending the financial resources available to you in each of the municipalities within your shared service arrangement. The second part is the service delivery tool, which captures the current services that are provided in each of the municipalities in your shared service arrangement, as well as how these services are shared and the capacity and expertise of the staff who are delivering these services to your communities. So how will this data be used? The cost tool data will be used to estimate current local public health spending across the state of Massachusetts, and then this data will be combined with the service delivery tool data and will be used to estimate the gap in spending that is needed to fully implement the foundational public health services in Massachusetts. So as Mike said earlier, we don't anticipate you to be fully meeting these services yet, but this tool is a way for us to identify any gaps and then hopefully help local public health to fill these gaps in the future. And this is a longitudinal process that's not going to be fixed in a month or a year or even 5 years. It's something that DPH is on a journey with local public health to work towards as we move forward to create a healthier Massachusetts. So the cost tool is the first tool that I'm going to be going over in a little bit more detail. So this is an Excel spreadsheet that is based in SharePoint, and anyone can have access to the cost tool for the municipality that they work with. And so in this tool, you'll enter fiscal year 2024 spending data, and then you will divide the spending across the foundational public health services, foundational areas, and foundational capabilities. So the first part is financial reporting. So you'll report your revenue, so all the money that's coming in to your health department through things like taxes, as well as things like grants and gifts, like the PHE grant, for example. Then you will report how you're spending this money. So this will be done by reporting staff costs, including full and part-time staff, seasonal workers, interns, and any contractors that you have. And then you will report your spending on contracted services. For example, if you pay Fitchburg for a shared nurse, but it's not a specific individual, rather it's just the nursing services, that would be an example of a contracted service. And then the last thing you'll be reporting is any operational costs that are related to public health services. And I'll show you the tools later, so I think that'll help make this a little more clear. And then the foundational public health services allocation will be used in all of the categories where you're saying how you're spending your money. And so you will be allocating to each of the foundational public health services, foundational areas, and capabilities. So what are the foundational areas and foundational capabilities? The foundational areas there's 5 of them, and these are really core programs that are topic-specific programs and services aimed at improving the health of the community. And so these include things like communicable disease control, chronic disease and injury prevention, environmental public health, maternal, child, and family health, and access to and linkage with clinical care. And then the 8 foundational capabilities are cross-cutting activities and skills that are needed to support those areas. So these include assessment and surveillance, policy development and support, community partnership development, accountability and performance management, equity, emergency preparedness and response, organizational competencies, and communications. And I understand that these are like vague words and not super understandable if you're just reading it and you're like, what is organizational competencies? We have definitions of all of these things, and if you don't want to read the definitions, you can schedule a meeting with me and we can talk through it. I'm happy to meet with anyone anytime to go over any of this information again or walk through any component with you in easier to understand language. So in addition to the foundational areas and foundational capabilities, part of this framework defined by the Public Health Accreditation Board includes community-specific services. And so we understand that not everything you do for your community falls under the foundational areas and capabilities that I just talked about. Some of them are really specific to your communities. For example, if there's a nurse in your shared service arrangement that provides home-based services, this isn't something that's available to the whole community. It's specific to certain individuals in your community, and this would be defined as a community-specific service. And so these services have their own spot in the tool, so we're accounting for the time spent on these services and acknowledging that they're super important work that you do for your communities, but we don't want to say that you're spending that time on the foundational public health services because it's really something that's community specific. So some tips for the allocation in the cost tool. So essentially you'll be dividing folks' time and the money spent on that position by the foundational areas, capabilities, and community-specific services. So just remember that these are estimations, and you can use just your best professional judgment about the types and amounts of labor and non-labor resources that you devoted to each foundational area and foundational capability in the last fiscal year. And for each labor position, think about if it's a programmatic area specific position. For example, if you're an inspector and most of your work is dedicated to environmental public health, you should start by allocating your time to the foundational areas. Then allocate the remaining time to the applicable foundational capabilities. However, if it's not a programmatic area specific position, for example, if you're in leadership, if you're a health director or a coordinator of some sort, consider starting with the foundational capabilities. So for example, maybe you spend a lot of time organizing meetings and doing things like that, that would fall under organizational competencies, which is a foundational capability. Maybe you are working on equity initiatives to make sure that there's an equitable distribution of resources in your shared service arrangement. Again, equity is a foundational capability. And then if you have time remaining, that would likely fall under the foundational areas, which are the bigger picture services. And again, like, happy to talk about this in more detail. I just know we're kind of short on time, and so I want to make sure that you're able to see the tools, because I think that's going to be really helpful in really understanding this process. So this is what the allocation portion looks like, and I'll go through this a little more when I go over the cost tool, so I'm going to skip over it for now and go into, actually, I'm going to go into the tool. So this is what you guys can see. Yeah, you can see the tool. Okay, cool. I will make that bigger. So I'm just going to do a short walkthrough of the cost tool. So there's a separate cost tool for each municipality in the shared service arrangement. For the sake of this demonstration, I'm showing, oh, this is the wrong tool. Ignore me. This is the cost tool, and I'm showing you the tool for Fitchburg just because that's your lead municipality, but each municipality has its own cost tool where you'll be reporting the financial information for that specific municipality. So the first tab in the cost tool is the instructions tab, and there are some high-level instructions and definitions that can be helpful in completing this tool. The next tab is the FPHS definitions tab, which explains in a bit more detail what all of these foundational areas and capabilities are. It provides descriptions for all of these, so that will be a helpful thing to start with so you know what each of these are. but once again, I'm happy to talk through them with you. And then there's examples of what each of these might look like in Massachusetts with these Massachusetts examples. And these examples in white were developed by folks in Massachusetts local public health. So we really hope that they exemplify what these things look like in Massachusetts to help you grasp what this could look like for your health department. The next tab is the glossary, and this just has more definitions and helpful things. I just want to highlight at the bottom of this tab, there is information about occupation categories. So one part of the tool asks for your occupation category, and here is some guidance on that. So it explains what is local public health leadership. So for example, that's someone that manages staff projects and policies. So you can use this table to help you distinguish occupation categories. And then there are all of the green tabs are data collection tabs where you will be inputting data. And I do just want to point out, Phil, your point to smaller towns not having the infrastructure to comply with all of these data collection tools, and I totally understand that. One good thing about the cost tool in particular is that the smaller the town, the quicker you'll get through the tool because you'll have likely a smaller budget and less to input. So it should go by pretty quickly. And again, I'm happy to sit down with you and help in any way that I can to help get that done. So the background tab, you're just going to put in information about the individual that is completing the cost tool. So this would be whoever has the financial information from fiscal year 2024. And then you'll put in the dates that encompass the fiscal year, how many hours a week are considered to be full-time in your municipality, and then the average benefits rate. The next tab is the revenue tab. And this is where, as I said, you are going to be putting in all of the money that is coming into your health department. So there are two tables in this tab. The first one is asking about sources of money coming in. So things like municipal funds from tax levies, things like permits, license fees and fines, and fees provided from another municipality. And then the second table in this tab is the other grants and gifts, or grants, gifts, and other funds, sorry. So this includes things like your PHE grant, the opioid settlement fund, and then you will input the amount of money that you received directly for this grant. So for example, Fitchburg as the lead would put in the total amount that they received for the PHE grant, and then they would indicate that they are in fact the fiscal lead for this grant as the lead municipality. If another municipality is filling it out and they get indirect funds from the PHE grant, they would just indicate that they're not the grant lead and that Fitchburg is. And then you'd indicate that, is it a regional grant, yes or no? And you would do this for all of the grants and gifts that you were awarded in fiscal year 2024. The next part is staff costs. So here's where you're going to be putting in all of the full and part-time staff that are on payroll in your health department. And for each staff position, you'll put the title. So for example, you would type in health director. And then you would indicate the occupation category. So if we're doing this for a health director, they would be local public health entity leadership. And then you would indicate the total full-time equivalency for this position. So was this position full-time, part-time? Fitchburg, I'm assuming he's a full-time health director, so I'm going to say 1. He works full-time. And then is this position eligible to be in a union? I don't know the answer to this, but for the sake of the example, I will say yes. And are they eligible for benefits? Yes or no? And then is this person a regional staff? So do they work with all of the municipalities in their shared service arrangement? You would just indicate yes and no. For right now, I'm just going to say yes. And then you would indicate the total amount of money that is funded by the municipality that comes from municipal dollars, and then the total amount that is funded by grant dollars. So if half of their salary comes from grant dollars, they would put the dollar amount that is funded by grants and then the dollar amount that is funded by municipal dollars. So I'm just going to put an arbitrary amount so that I can explain the FPHS allocation. So if we assume that their total salary is $60,000 and then we have to allocate their FTE, so by the foundational areas and capabilities. So we'll be thinking about what the health director does on a day-to-day basis throughout the year and how these activities and responsibilities are distributed across the foundational areas and capabilities. And so health directors do a lot of things in terms of policy development. They're in charge of talking with other people about policies for their department. So maybe they spend 40% of the time doing policy development and support. Perhaps they're working on a lot of equity initiatives for their health department and spend 20% of their time on equity. So you see over here that I've allocated 60% of their time already, and then you're just going to want to make sure that each of the staff positions that you input add up to 100% allocation. And you would do this for each of the positions in the health department. So again, if it's a small department or you only have one part-time staff member, you would only have one line item. Yeah, Phil?
So that's the issue with us little departments that only have a 4 or 5, all we have is a 5-hour admin a week. And then when you're trying to put in the hours, the part-time hours, that's an issue. And then the rest of us are board members, but we are working board members. So it's trying to, it doesn't let you really do, 5 hours a week. And then everything's supposed to add up. There's nothing to add up.
So if it was an admin position, I could help you do the math to determine what the FTE for a 5-hour a week position is. But if it's admin, it's likely that all of the time falls under organizational competencies if they're mostly just doing administrative tasks. So then you could just allocate 100% to that, and it would automatically, you would distribute you would have allocated all of their time. Does that make sense?
I guess.
And then the board members, if you are paid by the board, you would also be included in this, but if you're volunteer, then that would not be captured here, correct?
All right, well, that's the other thing. We do get a stipend, but the other thing in the small departments under funding, one of our major costs is some of us run transfer stations. So it seems like we have this huge budget, but it's because of the transfer station, and not all of us have that responsibility. In Winchendon, it goes under the DPW. Phillipston and Royalston, we operate transfer stations. Templeton doesn't, so it varies. So how does that, where does that fit in? Because basically, our primary focus is environmental health, number one. We do emergency preparedness through our coalition. And then the reason we created the network was for nursing. And then the rest are more esoteric, really, quite frankly, the other foundational requirements. So out of that list, this is on our plate, and that's basically our capability.
And that's totally okay and expected. So like Mike was saying, as in the capacity assessment, there are things that local public health doesn't have the infrastructure for or isn't doing in their communities, and that's okay. We want you to report that. We want you to say that you're not spending time doing these things, and that's totally all right. Part of the service delivery tool, which I'm not entirely sure if we'll have time for today, but I'll try to rush through, is indicating other people in your communities who are doing that. So for example, if there's a hospital in Fitchburg who's providing some of these services, or if there's like a community-based organization that's doing these things, that also counts as delivering the foundational public health services. And then if that's also not the case, which again is fine, we understand that that may be the case in a lot of communities, this is the opportunity to identify communities that don't have the foundational public health services.
Okay.
I understand, and it's totally okay. Like, if you only have environmental, public health, and organizational competencies in your cost tool, A-okay, you're doing it perfectly, and you're being honest, and that's what we want. We want the data to be accurate, not just stretched to seem like you're doing things differently than you actually are. And so you mentioned having Board of Health members who are stipend, and so that would likely fall under other spending, which is the last tab. So the staff cost is all the full and part-time staff, and then seasonal and interns, if you don't have any, you can just skip over this. This tab looks basically identical to the staff costs. And then same with hourly rate contractors, you have to do the same thing of allocating time, but it's just for folks who are paid hourly. And then the other spending tab is where you'll put any contracts. So you would put, for example, if you pay into the SSA for shared nursing services, that would go here. If you're paying Fitchburg a certain amount of money for those shared services, that would be a line item in this tab. And then you'll be allocating that to the foundational areas and services, or foundational areas and capabilities. So if you're paying for nursing services, it would likely go under things like access to and linkage with clinical care, or communicable disease control and chronic disease and injury prevention. And then we can also talk through what this might look like in your community, and the transfer sites, how the money is being spent on transfer sites, since it isn't a staff position. That would go under the other table in this tab, which is just operational costs. And so any money that is being spent to operate the transfer station would go down here in this table. And then you would allocate it to the foundational public health, foundational areas and capabilities once again, and you would say that that's 100% environmental public health. Yeah.
Just to follow up, so is someone available to come to our office and sit down with us as we plug this stuff in?
Yeah, I'm happy to do that.
Because I think that's actually the quicker way and probably less time consuming to do that. We would,
yeah, absolutely.
Our budget, we would just do it in real time. And then what's our deadline for this?
Yes, I will pull up the rest of the presentation. So you made a great point. I think for a lot of communities, doing this in person together or via Zoom together, like sharing screen, whichever works best for you, would be a really great way to do it. And I'm happy to help any community who wants to do it that way to do it like that. And you can just kind of talk through what each of the fields will look like for your community, and then I'll input that information on your behalf. Yeah.
And then where are you located?
I'm in Boston.
Oh, well, I'm going to say this. Coming out to see us would give you a really good perspective of where we work and the settings that we work. And I think that would be valuable for you to see the different offices. We're all different in some ways, but we all do the same in other ways. So you could have like Fitchburg, which, has a big office. Then you come to someplace like Royalston, and we're, sharing a room with other departments. And I think it would be really good for you to see that. It would really give you a real sense of perspective. I would encourage that, and I think will follow up with you to come out. And if you did that, you could, we're all within each other. If you came to us in Royalston, you could skip over to Phillipston, Athol, Templeton, make a day of it, not make a separate chip for all our communities. But I certainly would encourage that.
Yeah, absolutely. I appreciate that insight, and I definitely agree. I think me saying I'm from Boston gives people like I'm a city girl. I am not. I have lived here for 6 years, but I'm originally from New Mexico, and I'm from a census designated place in New Mexico because they don't have separate municipalities for each place, but my town is 200 people, and I've been involved in like their water board, things like that. I totally understand like small town structures and also how it's different in Massachusetts. So I'd be really excited to see your communities and how they function uniquely. And I'm happy to learn from all of you in any way that I can and help you complete these tools in a way that is reasonable for your communities. I am just going to hop into the service delivery tool. I know I'm like so short on time, so I really apologize.
Take your time, Tyler. Take your time.
So this one is asking about the services that are provided that align with the Foundational Public Health Services Framework and each shared service arrangement. So this whole SSA has one service delivery tool, but then there's a tab in the tool for each of the municipalities. And so I'm just going to go through all the questions that this tool is asking. So the first set of questions is asking about who's delivering services. So there's a drop down of yes or no for each of these questions, and you'll indicate who is delivering the services. So you'll select yes to indicate that your local public health entity delivered the headline responsibility. And the headline responsibilities are these statements underneath the foundational area of this is the example is environmental public health. And if another organization separate from your local public health entity and separate from your shared service arrangement delivered this headline responsibility, you would indicate that right here in the another org part. And then note that this My SSA column that is a bit darker will be filled out by your shared service arrangement staff. So the folks employed by Fitchburg that are shared staff, your shared service coordinator, they're the ones who will be filling out this column. So they'll already be indicating if the SSA provides this service to your community. So you don't have to worry about it. And once again, if your community doesn't provide very many services because the majority of them are provided by the shared service arrangement, it's okay and expected that most of this column will be no. And I also understand that it's super time consuming to go in and click no on a bunch of things. So if you want to just focus on clicking yes, or we can do that together, and then I can go in and answer no to any of the ones that you don't do later on and just do my little clicking. So that's a time commitment that you don't have to worry about. So for the headline, each headline responsibility, you'll also be asked to indicate to what, what was the responsibility attributable to your local public health entity. So you will select the % share that most accurately reflects the responsibility of your local public health entity. So if your local public health entity had no involvement and it was fully delivered by either the shared service arrangement or another external partner like a community-based organization or hospital or school in the area, you could indicate that you had no involvement or contribution. But if you partnered with the shared service arrangement, you could say that there was a 50% contribution and then or 75, 25, or 100%. And again, so for a lot of your communities, I think really just environmental public health would be something that you're delivering independently in your community, and that's okay. So you would just indicate that in the environmental health foundational area, and then the rest of them you would indicate that someone else is delivering that service to your community. So the next portion is to indicate your local public health entity's capacity to deliver the headline responsibility to your community. So you'll use this provided rubric or scale, and this exists in the tool as well, so you don't have to remember it or anything like that. It's in the tool itself, and you'll use this to rank your capacity to deliver this service. And so when thinking about capacity, you're thinking about the staff, other resources, materials, and supplies that are available to deliver this service. So thinking about providing timely, scientifically accurate, and locally relevant information on the environment and environmental threats and their control, what's the capacity of your local public health staff? So for this, we're only thinking about the capacity of the staff employed by your health department. So if we're thinking about a smaller town who maybe doesn't have the staff to do this, you could say that it's absent. However, if you're a town like Fitchburg, you might say that it's comprehensive. You have the staff capability to deliver this headline responsibility completely. And again, it's totally okay if you don't have these the capacity to deliver this service. And the shared staff will be answering separately their capacity and expertise. So we'll understand that if an individual municipality doesn't have the capacity to deliver this, we can then look at the shared staff and how they ranked their capacity and see that, oh, someone in the shared service arrangement does have the capacity to deliver this, and this resource is being shared across the shared service arrangement. On the other hand, maybe the SSA does not have the capacity to deliver this service because they don't have sufficient staff or materials, and this would be flagging that to us so that in the future we can work towards developing that capacity for your shared service arrangement. The second to last question in the service delivery tool is expertise. So using a similar scale right up here, but this one is asking about education, training, skills, credentials, and experience. So does your individual local public health entity have the expertise to deliver this? So in some instances, maybe a Board of Health member has very high expertise. You're highly trained. You've been in the field for many years. So you have comprehensive expertise, and you may have comprehensive expertise but absent capacity because maybe you do have the expertise to deliver the service, but you don't currently have the capacity to do so. And that's okay. We want you to just note that. And it's also okay if there's no one in the health department who delivers the service and no one who's able to, so your expertise would once again be absent, and that's all right. So the last column in the service delivery tool is asking about service delivery fulfillment. So to what extent did all of the organizations responsible for delivering the service fulfill the services required to meet the needs of your community? So here you'll use a similar Likert scale, 0 to 100% in 25% intervals to indicate the percentage that most accurately reflects whether the community needs were met in fiscal year 2024. So how did the local public health department individually in collaboration with the shared service arrangement and any other external partners, how well did all of those three entities together deliver this service to your community? Did you deliver it all of the time, rarely, some of the time, or not at all? And this is where you will indicate that. I do want to note that we understand that this is a kind of subjective measure because it's impossible for you to know what all of the entities outside of local public health are doing. So this is just using your best judgment so we can understand how you feel about the services being delivered in your community. I'm just going to open up the service delivery tool really fast. So similar to the cost tool, it has an overview tab and then with some high-level instructions for the tool. And then it has the same Massachusetts definitions, Massachusetts examples tab with the definitions of the foundational areas and capabilities. And then it has all of the headline responsibilities and then explanations of the headline responsibilities. So this tab will really come in handy when you're completing the service delivery tool because as in the other tool, this is language that isn't super familiar to people. Like, what does it mean to develop a plan to address gaps and barriers and assure access to clinical care services? If you read that and you're like, what does that mean? Here we have some examples of what this looks like in Massachusetts. And once again, there's a tab for each of the municipalities in your SSA. So I'll just use Athol as an example. So when you're starting the tool, you'll go in and you will say in progress to indicate that you've started the tool. And then you'll go through and answer all of the questions that I just went over. And if you read this one, for example, 1.03, which is under the foundational area, access to and linkage with clinical care, it's implement population-based strategies to improve barriers to accessing clinical care. And you're like, what does this mean? What could this look like in local public health? We have also an external document of Massachusetts examples if it's easier for you to like print out this document or have it open in another computer or somewhere else so that it's not flipping back and forth between the tool. You can open it up and read what this might look like in Massachusetts. So you might originally think that you don't do this thing, but then upon closer consideration, maybe you do have partnerships with local healthcare providers to implement initiatives, or maybe you do collaborate with partners and host enrollment events to help folks in your community enroll in things like Mass Health. In that case, you would then go back to the service delivery tool and indicate that you are doing that in your community, and go through the rest of the questions that I reviewed. And so again, a tab for each of the communities, and then the last tab in the service delivery tool is the SSA summary tab. And in this tab, you're able to see aggregated results from all of the communities in your shared service arrangement. So in May, we'll come back together and have an SSA-wide conversation where we can review the results from your entire shared service arrangement. And then the results in this tab will be used when you're planning, when you're doing your FY 2026 planning. This was a kind of chaotic presentation, so I apologize for my chaos. The last thing I had here, which is a question you asked, Phil, which is when are these tools due? I think that's actually going to mess it up. So the cost tool is due first. It is due March 14th. And then the service delivery tool is due on April 18th. But once again, if I come in person to your communities, or if we find a time to meet for a chunk of time, especially for the smaller communities that don't have as many services that you provide and you don't have as many staff, I'm confident that we could crank it out in a day. Any questions? Sorry.
Don't apologize. It's very helpful.
Yeah, no, you did great, Kayla. Thank you. I'm sure questions will come up and we will go to you, or I will go to you with those. One of the things that I asked you when we met, and I want to point out to everybody, is that it doesn't matter the order. So like you showed the SSA tab on there, that is mine and Steve's responsibility to go through, that we're going to go through those together, and I'll be checking those off. You can still start on your tool if it is good timing for you now to be working on it. But I have not done my part yet. So just so you know, I have not started it. So of all the questions that each of you have to do, I have to do that times 13. So it will get done. I am confident of that, but it has not been started nor nearly finished, of course. So, but that doesn't hold you up that I haven't done that part yet. So just wanted to make that clear for everybody.
Yeah, thank you so much for that. And they also have my email address and can share that with you. It's just K and then my last name at bmestrategies.com. And feel free to reach out anytime. I'm happy to schedule a time to meet with any of you. I also started offering office hours during the week that Catherine knows about, so she can share those times with you as well, and you can ask any questions during those times also.
Yes, thank you. Office hours are coming. Kyla did send me information about that late yesterday that I haven't picked through yet, but I will do that. And I plan to send everybody that's here and everybody on our general email list for the MPHN out kind of a follow-up to this meeting with the links that are provided and Kyla's information and all the next steps kind of printed out for everybody so we can have a summary of today.
Excellent. Any other discussion, questions?
Catherine, just so you know, I'm sending the slide presentation for today, the allowable expenses, the blueprint executive summary, an advanced description of the program that we did a couple of years ago, of the whole PHE programs. It's an overview, and our guidance document on the SAFE Act.
Fantastic. I'll get that to everybody. Thank you, Mike.
Okay.
And thank you both again, Mike and Kyla. And I can't stress enough to everybody that both of these folks who joined us today have been incredibly effective at speaking with me to help my understanding of everything, and also very, very responsive to any requests and access. So we have great tools to use, and we just need to use them. Thank you both.
I second that. Any other discussion regarding Kyla's presentation? Hearing none. Moving on in the agenda, thank you all, is announcements. I do not have any announcements. I don't know if anybody in the MPHN has anything to announce.
I do have to hop off, but thank you all so much for having me. So thank you.
Thank you, Kyla.
Thank you, Kyla.
I have one thing, Steve, that I'll share. I have been working, and I know Stacy does also, and I'm not sure if any of the other communities in the MPHN do this independently, but I've been working with the Blood Mobile for Mass General Hospital to try to get them to schedule regular blood drives with us. We've done a couple in Fitchburg, but for some reason I've never been able to get a regular schedule. I just finally got them to get a regular schedule for blood drives in Fitchburg, and so I just wanted to put it out there. I'm not sure if any of your communities already have blood drives scheduled, whether it be through the health department or through other organizations in your municipalities, fire department, schools, etc. But if any of you are interested in hosting a blood drive in your towns, please feel free to reach out to me, because I think I have finally got through to the contact at MGH, and it will be much easier for me to get these scheduled now. So reach out to me if that's something you're interested in, and I'd be happy to get that going in your towns if that's something you'd like.
Thank you, Victoria. Is there any other announcements?
I have one more too, Steve. We have 2 vaccine clinics this week. Tomorrow we'll be in Leominster City Hall all day from 9 to 5, I believe, doing flu and COVID vaccines. Walk-ins are welcome. And Friday, the same time, 9 to 4, I believe, at Fitchburg City Hall. So tomorrow, January 30th, Leominster City Hall, and Friday, January 31st in Fitchburg City Hall. Flu and COVID vaccines.
Thank you for announcing those. Anything else? Hearing none, I'll entertain a motion to adjourn. I think we've got enough information.
Susan had her
for one
hand
day.
up. Susan had her hand up.
Oh, I'm sorry, Susan.
Not really an announcement, it's a question for Catherine. So when we have the MPHN meetings, we're supposed to post them in our local communities, correct? And would you be sending us that information that needs to be posted?
Yep, that's what I send a few days before the meeting. So like last week when I sent out the agenda, that's the agenda that should be posted in each community. And, and I put that reminder in there when I send that out to post it as appropriate for open meeting law.
Okay, just checking.
Have you all decided not to adopt the abbreviated posting method, or do you not know about it, or what?
Yeah, I do know about it, Mike. We haven't put it on an agenda, but it is in my brain to do that in the near future.
I'll forward you the guidance for that, but there is a way that makes it so that none of the other towns, other than the actual Montachusett Public Health Network, need to post these. And so you won't be needing to bother your town clerk. And I'll send Catherine the roadmap for how to do it. We've even included a script. You know, Mr. Chair or Madam Chair, I have a motion, and for your Board of Health to adopt it. But then what happens is, once you've adopted the system, you post on your webpage that you belong to the Montachusett Public Health Network, and that the network has meetings on occasion. Please consult their website and you put a link in, and your town clerk knows how to do this. You put a link into your webpage, and they click that, and it takes them right to the next posting on the Montachusett site, and you never have to post again. Only Montachusett would have to post.
Yeah, we'll try to put that on the agenda for March.
Okay, and if you need, after you've seen it, if you need me to drop in and give a quick overview of it, I'm more than happy to help out in any way that I can.
Fantastic. Thank you, Mike.
And then one more question on kind of on that line. So I know that as we're already members of MPHN, does there anything that the Board of Health have to do to renew that membership yearly, or to address it, or anything like that? I'm just trying to ask because of other things that have come up in Gardner's Board of Health that have been questioned about from public, about our agreements or connections with other areas like.
Yep. So that's in the IMA. Is that right, Steve?
That's correct. And our renewal system is fiscally, it's done, we started in May and June, so you can fit it in with your next fiscal year budget. It's basically the opt-in sheet we send out every May and June. Basically, you get to select your services that you're interested in. Some of the items do have a retainer, a cost retainer. But that's done annually.
So is that something the Board of Health itself has to vote on to, when that's done? I guess that we've never done it that I can remember, and I'm just trying to clarify that.
I fill that out on a yearly basis.
Okay, so it doesn't have to come through us, through the board itself?
Not that I'm aware of, no.
It's through the town, right?
Yes,
through
correct.
the town, yeah.
Okay, I just want to clarify. Thank you.
You're welcome. Anything else?
Motion adjourn.
Motion from Phil to adjourn. Do I have a second?
I'll second that.
From Micah. Have a good afternoon, folks. Thank you.
Steve,
Yes.
need a roll call.
Thank you.
My apologies for not stepping up on that one. Okay, roll call. Clinton? Fitchburg?
Fitchburg, yes.
Gardner?
I was going to say something.
Hubbardston?
Yeah.
Lemonster? Michelle, you're on mute. Lemonster? Royalston? Phillipston? They signed up.
Yes.
Okay. Sterling?
Yes.
Templeton?
Yes.
Westminster?
Yes.
Winchendon?
Yes. So there's only one phone number on here.
That was painful. We are adjourned.